multidisciplinary team aimed at improving the service experiences of 16 to 24-year-olds with mental health and substance use concerns, as well as their families. The goal of our TLC, or transition and linking to care team, is to build healthcare providers' capacity and understanding of this population through consultation and education. And then our hope is that our education will ease the transition process for young people as they go through their developmental and mental health journey.
And for those of you joining today, this is a session really for Richmond community teams. And so we've been working closely in Richmond for the last year. So really great to see so many of you here.
Okay, so what are we going to talk about today? So our learning objectives for today are to highlight the value of including family and or chosen family in treatment, discuss privacy policy documents and clinical practice implications, demonstrate comprehension and application of privacy policies through a couple discussion questions, identify strategies to engage with families and caregivers, identify strategies to work through resistance or challenges with family, and then to highlight in plain sight findings and implications on care. So first, before we get started, we do just want to do a definition of family. So family-centered care is a mutually beneficial partnership where family is included as a valuable part of the team. So this could involve inclusion in assessment, education, decision-making, discharge and safety planning, and resource connection. So anyone that the patient or client has identified as part of their care team is referred to as family throughout this presentation. So this can include, but is not limited to, a parent, a guardian, whether it's an MCFD social worker, a parent appointed guardian or a temporary guardian, a friend, any extended family members, aunt, uncle, cousins, dependents, so children, partner or sibling. And we do have just a little note here at the bottom that when we say 19 plus, that is with regards to anything to do with the Mental Health Act. So if you have someone signing any paperwork, they do need to be 19 plus. But of course, having, your children or people in your family involved in your care under the age of 19 is always welcomed. Just for legal purposes, that's just in reference to paperwork that you're getting signed. So just a question for the group, and feel free for those that are online to either unmute or even just put it in the chat. So what are some of the barriers or challenges you have encountered in providing family-centered care? And also open to the small group here with us as well.
Maybe we'll start by picking on those in the room with us. Any barriers you've encountered to providing family-centered care?
I think one of the barriers I'm thinking is also sometimes our clinicians' capacity to be able to provide a full care to families because they are picking up a lot of caseloads with use and it's a lot of work, right? And also I'm just trying to think about hours as well. Parents, working parents who may not be able to meet with a certain time that will provide cares. Sometimes family resistance could also be a part of it as well. Language capacity could also be part of the barriers. I mean, our team is quite equipped with Mandarin and Cantonese speaking.
Yeah.
But sometimes with the people who speak other language don't have capacity to be able to provide. Yeah.
Yeah, so definitely clinician time, when you slot in a patient for 30, 45 minutes involving the family can take an extra amount of time. And then also with working schedules, like, we work Monday to Friday, 9 to 5, but healthcare providers might work different hours and things like that. And so that doesn't always meet the needs of the families. And language barriers, that's a huge one. And it's great to hear that you guys have clinicians that are fluent in Mandarin and Cantonese, but also acknowledging all the other languages that may be present. And that could be difficult as well to support those family members. Yeah. And then I see here in the, oh, I see. Yeah. Oh, you're responding. Otto's put in the chat as well for those who didn't hear. Yeah. Anything else that's made involving family and care difficult?
Sometimes in terms of family members, they won't always agree with the treatment So navigating that, figuring out like how to middle and include them as well in terms of the client's care plan.
So family members maybe not agreeing to aspects of the care plan or the discharge plan, or not agreeing with even the discharge in general, that needs to be longer, we want them home sooner. Yeah. And then in the chat, Sean here said interpersonal conflict within family. Yeah, that's definitely a big one, especially when you think of 16 to 24-year-olds, right? That can be a big time for disagreements with family. We want independence, we want to make our own decisions, but the family still may be heavily involved in their care, so they want to have a say as well. Yeah.
That can even look like perhaps parents that are divorced and parents having different perspectives on care and maybe not having the communication or the consistency between the two of them.
Anything else you guys can think of? So we've highlighted a number here that we've heard in previous sessions, but hesitancy of young people to involve their family in care. I want to do it all myself, or I don't want my family involved. They're over involved. Interpersonal conflicts, like Sean mentioned. Different goals, values, and beliefs within family regarding treatment. So maybe the family has very different ideas of how they want to go forward with treatment, and that looks maybe different than the care team or even the youth or young person. Patients who lack a strong support network or whose main support network, oh my goodness, is not local. So for young people who are living here alone, or maybe they're here as a student and their family is in another place, and they don't have that immediate support that they may need. Time constraints, language barriers, difference in biological age and functional age relating to physical and intellectual disabilities and societal and cultural impacts. So some youth in their 20s and 30s may still be living at home because of a lot of reasons, but housing crisis, that kind of thing, and remaining more dependent on parental support with IADLs, like finances, managing appointments, cooking, life skills, daily living functions, uncertainty about confidentiality. So we're going to go into a little bit more detail about confidentiality, but some youth may not want their families involved because they don't understand what the limits of confidentiality are, or what we will share, might not share. And then families with high expectations or high needs. Yeah. So why do we want to include family in care? So why does it matter? What does the research say about including family? So involving family members as a key part of the care team has been shown to improve patient and family outcomes. It is more culturally relevant and sustainable with regards to the interventions. Reduced need for future utilization of acute healthcare services, so like emergency departments or high acuity units or teams. Increase family awareness on how to support and reinforce their family members' recovery. So that kind of goes hand in hand with that use of acute services. When families are prepared and they know what to expect and they're involved, they're less likely to be in crisis necessarily, or they can handle the crisis better because they know what to expect. Improve patient and family coping skills. Reduce caregiver burden. This is a huge one. So when you have one person that they're relying on, maybe it's a parent, maybe it's a partner, that's a lot for one person to take on. And so if they feel prepared and supported, they're less likely to experience that caregiver burnout or burden that sometimes can lead to, them stepping away from care. And what does that mean? If it's a child, it could be a situation that now we have a housing issue, or we have like not limited supports. So we do always want to be considering the family in that case too, and the burnout that they might experience. Increase social supports for family. So having somebody around you we know everybody likes to have somebody and needs to have somebody, where we want human interaction. And so having a family or support people is really important for people's recovery. And then increased likelihood of returning for necessary treatment due to a positive client and family experience. So if a young person has a great experience with their first mental health interaction and their family felt heard and supported, they're likely to come back and seek treatment, versus people who are forced back into treatment and family might not want to engage. And that's where we see some of that resistance or challenging behavior. So we're really trying to avoid that by working together and making sure that they feel included and heard in whatever way they can be.
Can I also just add a point? So I'm Otto, I'm the social worker with the Missing Middle TLC team. So an interesting statistic that you're probably aware of from StatsCan in 2021, about 35% of young people up to the age of 25 are still living with their parents. So we can also talk about economic realities too, where because of housing costs that I think younger people are having to rely on families and living at home. And so that's something we might anticipate as heading into the future, is having more family housing. And that's one of the issues we hear over and over again from Richmond teams and other places. It's like housing is an issue. And there's a lack of supported housing. So really family can be the critical piece.
Okay, so traffic lights of disclosure. So this is something I found quite useful when we think about confidentiality, what we can share, sharing of information. And so I always enjoy a like a nice acronym or anything to do with pictures or visuals. So if this is a helpful way to think about it, so the traffic lights of disclosure. So red is you may not disclose. Yellow is you may or may not disclose. There's a couple different things you have to consider there. And then green is you may disclose. So we're gonna go into each one of these to really understand them better. Starting with red light. So we can work, so a lot of these articles or a lot of this information is based on like the Freedom of Information and Privacy Act, so FIPA, PIPA, all those acronyms. But essentially to kind of break it down into simplest forms is that we can work backwards from authorized disclosures to conclude that disclosure is usually not authorized, so we cannot disclose if the disclosure is not for the purpose of continuity of care and disclosure is not mandated by law. In other words, the individual requesting the information does not have the right to have it. It is not authorized if you are disclosing more information than the person you're disclosing information needs to know. So that's that term needs to know basis. And then lastly, you're not authorized to disclose if the patient does not consent and the information is not required to provide care or services. So we do have an example here. Disclosing to a parent that their child, a 15-year-old female, is sexually active when the child presented to the hospital for anxiety. So that doesn't apply. So it doesn't meet any of the criteria listed above. There's with this face value, there's no safety concerns, right? We don't know anything necessarily about them being sexually active, but at face value, it doesn't seem like there's any safety concerns there. It doesn't need to be provided on a needs to know basis. It doesn't apply to their care for mental health supports. So we would not be sharing that information. There is a note here if you're curious about the age of consent in BC. And so there is a link here as well that talks about that when we are considering if this was someone like, say, like a 9-year-old, that's a very different story. And age of consent comes into play there. But for the purpose of this example, this would not meet the qualifications to share information.
And we will be sharing all these slides out. So if there's links in here, anything, you will have access to all this.
Yeah. Another example of this is a young person presenting and providing a UDAS for drug screen. We are not required to provide the results of those. So another example as well that maybe is more applicable to mental health. Yellow light. So I would say working in mental health specifically, this is like that gray area, right? I would say majority of situations that we come across are really in that yellow area of what do we do? We usually need more information or we need to work with the information we do have and make a decision. So yellow light, this is a quote from FIPA. One may disclose personal information for the purpose for which it was obtained or compiled or for use that is consistent with that purpose. So this has been interpreted to mean that information for continuity of care purposes and on a need to know basis. So in order for us as healthcare providers to provide care, we do need to release this information or share it with whoever we are sharing it with, but on a need to know basis. Do they need this information to provide care? No, then we do not need to share that information. So the important thing about anything around that yellow light of disclosure is that interpretation and healthcare provider judgment is often required. So I do want to put a plug in here for the importance of team members. So if you're having a situation where you don't know if you're supposed to be sharing information or you're wondering or you're on the fence, It's really important to be talking to your team leads, to your colleagues and running that by them, right? Because sometimes in these situations, we may not know what we need to do, or maybe we haven't had this experience before. As a new grad, I didn't have any experience with this. I didn't talk to families. So when you're gaining that experience, it is important to rely on people you trust in your team as well to run it by. What would you do in this situation? Do you think there's more information that I need? So PIPA uses a reasonable person test, which means disclosure of information is authorized only for the purposes that a reasonable person would consider are appropriate in the circumstances and that fulfill the purpose for which information was collected. So essentially, if you lined up 15 different people, 14 out of 15 would agree that that was a reasonable thing to share. So that's what a reasonable person test is. The majority of people would agree, yes, you probably should share that information. It applies to continuity of care and it's on a need to know basis. So as healthcare providers, we provide care under FIPA, but the reasonable person test is a helpful tool to gauge gauging collection of data, use and disclosure. Another example under kind of the yellow light where is a 18-year-old patient is being transitioned from child and youth services to adult services. Clinicians provide handover to the newly receiving team on psychiatric history and treatment. So you would be providing the history on the psychiatric treatment, that's continuity of care, they're taking over, but you would provide what they need to know in order to provide care.
And like Steph said at the start, if there are questions coming up or comments, feel free to raise your hand, unmute, put them in the chat as we go. Don't feel like you're going to interrupt us. Yeah. And we will have time for questions at the end as well.
So green light. This is a quote from FIPA again. FIPA mandates that information must be disclosed when there is a risk of significant harm to the environment or to the health or safety of a group of people or the public. So some examples of this are when there is suspicion that a child, so anybody under the age of 19 in BC is considered a child, I guess in Canada as well, under 19 is considered a child. So if they need protection, when there is a risk of serious harm, anyone with reason to believe a child is being abused or neglected or is at risk for abuse and neglect has a legal duty to report that concern to a child welfare worker in MCFD or to a delegated Aboriginal agency child welfare worker. So essentially, as healthcare providers, we are all mandatory reporters. So if you are concerned that somebody under the age of 19 is at risk for serious harm or is currently being seriously harmed, you do have a legal obligation to contact MCFD. So you do not, as a healthcare provider, need to provide proof. So if a young person comes to you and tells you, this is what's happening to me, it qualifies for mandatory reporting, you do not have to provide evidence. So you don't have to go and talk to the parents and understand the housing situation. That is the obligation of MCFD as well as the police. So proof is not required and MCFD is obligated to investigate these allegations. So we do have a note here that legal cases may involve medical record requests. Connect with your supervisor for instructions on how to proceed. So as a healthcare provider, if you're working as part of a team and someone comes up to you and says, I'm so-and-so's lawyer, he's in a court case for assault, you don't have to provide those records. You need to talk to your supervisor. There's a special process for requesting that information. You don't just blindly provide. Even if they are a lawyer or a police officer, you need to ensure that your supervisor is involved in that.
My understanding with police too is they need to have an active case file. And they need to share that with you in order for you to consider the request.
Yeah. I've had an example, this is maybe not as applicable to community, but I've been on an inpatient unit where the police literally showed up to the door and said, we need this patient's toothbrush. And the nursing staff were like, well, like they're AWOL, like they had run away from the unit and potentially committed a crime. And the police were quite insistent that we needed to do that. So we ended up having to get like site leader involved and everything. And they actually deemed there was no warrant that like made it applicable to the unit to do anything. And of course the police were quite upset about that. But at the same time, you do also have a legal obligation to your patient, right? They might not have committed this crime. We don't know. And that's not our job to know. We do have a note here that a child is considered anyone under the age of 19. So if over 19, the principle of duty to report under common or case law can apply. So some examples of when that would apply is imminent risk, self-harm, or a vulnerable person at risk for being harmed. And however, this should be in consultation with risk management. So always ensuring that your team is aware, and that your team lead or supervisor or manager is aware of these cases, because it's not something that you deal with on your own. You need that support. I also do want to make a note. I'm not sure if there's any social workers on the chat here. But I'm sure they'll appreciate this note that I always make, is that if you are the person taking the report of any abuse or concerns of abuse, you have to be the person to make that call. It is not a situation, for example, as a nurse, if I take that report, I'm not gonna go to Otto's office and leave a note on his desk to make that call to MCFD. So it is the person who took the information, who completed the assessment, who received that report, needs to be the one to call MCFD. An appropriate use of your social work on your team would be, if you've never called MCFD before, to inquire about what questions they will ask and what information you need to have prepared prior to that phone call. There are some unique questions that are specific to MCFD, but as far as the person reporting it, it needs to be the person who heard it.
And usually it's very basic information, like who the person is, contact, just a brief description of the situation, why you're concerned.
Awesome. So we do have a couple examples here. So we'll go through these. Oh,
Seems like a funny order. Why don't we go into the case scenarios first?
yeah, that makes sense. So the discussion scenario. So feel free to comment in the chat and as well here, whether or not you think this is yellow light, green light, or red light. If it is yellow light, what questions or what more information may you want to know in this situation? So the first scenario here is that a patient who's 24 years old is being admitted to the inpatient psychiatry unit for an intentional overdose on Tylenol. She doesn't want her parents, who live in Mexico, to know any information about her admission. So is this something that you would disclose to the parents that she was admitted to the hospital? And feel free to put up your hand or respond in the chat as well.
I feel like the term red light, green light has been ruined for me by Squid Game. But yeah, feel free to just put in the chat what your guess is. No wrong guesses. Green, yellow, red. We're all kind of learning together. So what's kind of your first instinct?
Any ideas from the group in person?
Or maybe what might you need to do first in order to make more of a decision around red, green, or yellow light? Yep. Chris.
Yeah, definitely. So when we talk about family, we are referring to anybody in the person support network. So does she have a relationship with the parents? No, they live in Mexico. We haven't talked in 5 years. Well, who do you have here in the community that we can support you with? Do you have a friend? Do you have a partner, a roommate? And thinking about someone who's had a suicide attempt, a very serious suicide attempt, that isn't someone we would just discharge and say, well, like, no supports, right? Like, we want to make sure that if there is someone to check in on them, right? So would you say that that would make this more yellow then? In that sense, where you're thinking, well, there's a little bit more information we would want to have. Yeah. So there's questions that we would want to ask. Do you want us to call your parents? Do you want to call your parents? How involved do you want them to be? I don't want them involved at all. Okay, well, who are your supports and what can we share with them? Right? If it's a roommate, that might look very different than a best friend or a partner or a sibling. Yep. We can go to the next one.
Did we determine the color for this one?
Yellow. So it was discussion scenario number 2. A patient, age 14, discloses they blacked out drinking alcohol last weekend and crashed their bike. They are here in the hospital for a sprained wrist. Would you say that this is information that family needs to know? Or not, or maybe? So red, green, or yellow?
And it would be great to have some participation in the chat from those that are joining hybrid. There's really no wrong answers, but just kind of first guess with what color you think this one might be.
Green, okay. Any other ideas? Yellow, yeah,
Thank you. Yes.
okay. Green, okay. This is why I like this. This is my favorite discussion that we do. Because these are things that have happened, right? Like these are very, like, in my opinion, working in the ER, these are situations that come up a lot. So when we think about continuity of care and when we think about the reason that we received the information, so they're in here for a sprained wrist. And they're 14 years old and they blacked out drinking alcohol last weekend and they crashed their bike. So that's the reason for the broken wrist or sprained wrist. Does that apply to healing their sprained wrist right now? These are just questions that this isn't to lead anybody in a different way, but does them blacking out have anything to do a week later with their sprained wrist that they're here to see? Not really, right? In our last education session we had, somebody proposed the idea, well, what if this isn't the first time that this has happened? What if we look at their chart and they have 60 visits in the last, 2 years for intoxication or substance use or minor accidents like this? That looks very different than a youth who just presented for the first time in their life, right? So that's something to take into consideration. What's the history here? Do we have maybe a substance use problem that might warrant offering some extra supports, like a substance use team, or looking into that if the patient is agreeable? And then that would lead to a larger conversation. Does the family need to be brought into that conversation? But I think at face value right now, this is a situation where we likely wouldn't provide that information to parents. We would do some more investigating to understand what the concern is. So that one we would classify as yellow.
Sorry, when you say you could disclose that, should you to the drinking?
Yeah, so the drinking part, yeah, so the sprained wrist, I'm assuming that the young person has a sprained wrist and they asked to come to the hospital and the parents are understand why they're there. But as far as the drinking part, I would not disclose that, yeah. And if there are any questions in the chat or as well, like, feel free to talk this through. I think what, like I said in the very beginning, the benefit of having a team is that you can discuss this. So not every answer that I say is always necessarily going to be the same as what Otto or what Sarah would say. That's the benefit of having a team to look at it from a different angle. Okay, number 3. A patient age 23 is being discharged from the inpatient psychiatry unit to his parents' home where he lives. He was admitted for psychosis and paranoia related to his parents poisoning his food. Do you think his parents should have information about his care? So red light, green light, or yellow light. So they should have information. They shouldn't have any information. He's 23 years old. Or maybe there's some information that they would benefit from. Yep. So we have someone in the chat says yellow. A couple people said yellow. Okay. So I think the most important part for me is the last part here. So he previously has had some psychosis and paranoia related to his parents poisoning his food. So if his parents are going to be looking after him and are his primary supports, if that's determined, then his parents would benefit from understanding what his diagnosis is. What does it look like when he's unwell? So when he starts to deteriorate, what do those symptoms look like? When his medication has side effects, what does that look like? What medications is he taking? Does he need support taking them every day? Is he someone who maybe forgets and needs reminders? Or maybe support even just getting to the pharmacy to take the medication? Maybe he has to get an injection, right? So maybe maybe he doesn't drive and he needs support getting to the appointment with the nurse to get his injection, right? And also from a safety perspective. So there's some paranoia related to his parents poisoning his food. Are they at risk for him trying to hurt them if he becomes psychotic again? So this isn't necessarily a green in the sense that we would open the chart and give it to the parents. But that being said, anything that would be pertinent and need to know for them to provide him care and to ensure their own safety would be needed to be shared. So those are some kind of examples. So medication, treatment plan, maybe follow-up appointments. And things like that would need to be disclosed in that situation. So everyone's saying yellow, that is correct. You wouldn't disclose everything, but there is an element of information that you would disclose. Does anybody have any questions about that? On the chat or in person?
Well, and one principle, whether it's yellow or green, is the need to know. So you only want to provide information on a need to know basis, whether it's green or yellow.
Okay. What I will do is I'll hold off on the last one because I want to make sure we have enough time here. And I'll hand it over to Sarah as well. I believe you're next on the slides here, Sarah.
Yeah, I think we're actually okay for time.
Are you sure?
Yeah, we have till 12:20. Okay,
No.
Okay, great. Sounds great.
I'll hand it over to Sarah, but I'm happy to discuss those. We will be sending out the slides. This is the Vancouver Coastal Health Family Involvement and Privacy document. So if you are curious what your governing body at Vancouver Coastal says about this, it is policy to ensure that family is included in some way in the care, in whatever capacity that could be, and in agreement with whatever the patient is wanting as well. So that's just essentially what this is saying.
And if you take one thing away from our presentation today, we've done a lot of focus groups with youth, and we had one last week where we were actually talking about family-centered care. And when youth were under 19, they said that, you know, it was really hard for them with the way that their family was involved, but they did say that they see the value in having their family involved. For them, when they're under 19, it's really important they feel like they're approached first and talked to about how would you like your family involved? What are your concerns? If there's a concern about a specific person being involved, can they support or give education to that parent? And so that was a really important piece for them. And then once they turned 19, a lot of them noticed that there was a big drop off in family-centered care. And as young adults, they actually wanted their family involved more. And so just really working with that young person to kind of make sure that we can involve them in the way that works for them. That's kind of the main takeaway for me, has been just really, really working with that young person for a way that that's going to work. So quick summary here, we talked about that consistent use, that need to know basis, continuity of care, a duty to warn, getting collateral, or if we need more information to make a decision about confidentiality. Also a note with collateral is that a patient might decline to consent to family being provided information, but clinicians can still always gather information from those family members. And that reasonable person test that we talked about. So moving into some clinical strategies. So this next part will be around some strategies for working with families and for understanding some kind of unique components about culture and families with family-centered care. So with building trust with families, we want to make sure we understand their beliefs and expectations of mental health care and ensure they have accurate information. How many times have we had a family show up to our service and they might have been told that your service can provide something that you actually aren't able to provide, right? Or in the hospital, them thinking that a lot of things would get solved or fixed before someone is discharged, when we know that a lot of recovery happens in the community. So really helping the family get on the same page to understand what you can offer. Using lay people's terms in education. We know that we use a lot of acronyms, we use jargon, right? Even sometimes with each other, we don't know what acronyms are. And so imagine how hard that can be for a family. Honesty, integrity, empathy, assisting them in problem solving. And then most importantly, we are not always going to know what to do in a case. And so being honest about that and saying, you know, I don't know the answer right now, but let me go find someone who does and let me come back to you. That really helps build the trust as well. In terms of strategies that we're going through, we recognize a lot of you in this session have a lot of experience in mental health substance use and working with families. And so some of these will likely be foundational and review for you, and some of them might be a new or a different approach, but we really want to welcome all of you to share your kind of wisdom and things that have worked for you. So with empathy, we know that this might be one of the scariest and most stressful days of a caregiver's life, right? And if any of us are going through a big period of stress, we are not always showing up as our best self in that moment. This admission or intake may have been a long time coming. They might have been on a wait list for a while. They might have had a really hard time convincing their loved one to come in for help. So there might be a lot of associated stress and burnout from that. We also know that families can often fear judgment due to those societal assumptions that poor parenting has caused or contributed to their child's mental health. In some cases, this might be happening, but we know in a large majority of cases, families are really doing their best and wanting to be there and support their loved ones. So due to this, it's really important to offer that non-judgment, that curiosity, and that support. And we want to listen to understand first, rather than listening to respond with our own agenda. Validation. So we understand where the other person's coming from, even if we disagree with what they say or do. We want to acknowledge that their experiences and feelings are important and valid. And we always talk about whether it's a code white or a situation with the patient, or whether it turns into a big breakdown of a relationship with the family and the care team. Often if we started out with validation, many of those later challenges would have gone away, because the first thing a person wants to do is just feel heard and listened to. So letting them know, it can be really challenging to get the help your loved one needs, or it sounds like this was a really scary experience for you. Really just letting them know that you are validating what they're going through, because it is really hard. Normalization. So ways in which we can help prevent, minimize, or reverse the psychological and behavioral manifestations of being viewed as different from society. That's a pretty wordy sentence in the spirit of us using more lay people's language, but all we're really saying is people can feel really stigmatized, or like they're the only one going through this, and letting them know, hey, a lot of families I work with feel the same way, or it can be really hard for a parent, and I hear this a lot. So it's really common for parents in your situation to feel scared or worried about self-harm, is an example of that. Paraphrasing. So repeating back your understanding of what was said in your own words. And the paraphrase kind of reflects the essence of what something has been said. What I really like about paraphrasing, I know this is a really simple strategy that we've all heard or learned before, is that not only are we making that parent or that caregiver feel heard, we're also checking to make sure that we're interpreting what they're saying right. Because sometimes I'll paraphrase back and they'll say, no, that's actually not it. What I was trying to say was this. So it's a really good way of making sure that you're on the same page with family. So an example might be, what I'm hearing is that you don't feel supported by your son's current healthcare practitioner, or it feels confusing to navigate a system when you're being sent to multiple different clinics for the same concern. Clarifying. So very similar to the one before, but open-ended questions that are used to make sure we fully understand what the family member means. So if they say that their child threw a fit, well, what exactly did he do? What does that look like? We know some caregivers might have a really high threshold of tolerance for a challenging behavior, and for other caregivers, a very low tolerance, where a really small thing they might see as being like an absolute fit or an absolute disaster, right? And when they say that they think a person's manic, what symptoms are they referring to? We know that online, and depending on what sources we're getting, some of the information about mental health might not be completely accurate about what someone's seeing on TikTok or on social media. And so wherever we can, directing them to those evidence-informed tools like Kelty or any handouts you have within your clinics. And behavioral incidents. This is terminology that comes a lot out of the behavior intervention world, but a behavior incident can be considered a single separate behavioral event. It has a clear start and finish, and it may be combined with other events to form a behavioral sequence or a pattern. So it's a really helpful tool for us that kind of can allow a parent to make a connection between an incident and a behavior. So getting them to walk back and say, okay, before that big explosion happened, what was going on before that? What were you seeing in your child? What were some events that were maybe triggering it? And then how did things play out? This is really powerful because it can really help work together with them to develop some interventions to kind of notice those patterns and see what they can do. And working through resistance. So I think the word resistance can often have a really negative connotation, but we know that all the word resistance means is that a person might be needing some time there might be kind of an unmet need happening. There might be some fears, there might be some anxiety, there might be a miscommunication. But when we say resistance, we just mean a time where we want to support the family with feeling like they're being supported and getting to a place where the team and the family is on the same page with what's going to be most helpful. So this is just a case study, and it's actually Richmond based, which is fun, but see what we did there? So Colin is a 20-year-old Chinese male attending his first appointment with your community MHSU program. He has a history of polysubstance use, anxiety, depression, and suicidality. He lives in Richmond with his mom, dad, and younger brother, who's 13. His mom, Anne, drove him to the appointment and asks if she can join the appointment with you and Colin. Colin reluctantly agrees. During the appointment, you notice Colin is possibly minimizing his concerns or problems and wants to be left alone. Anne attempts to provide more information to you, but this starts to agitate Colin and he asks her to leave the room. How would you build therapeutic rapport with Colin and his mom, Anne, in this situation? Where'd that go? There we go. Any thoughts in that? Does anybody on the chat want to unmute or chime in? Either in the chat, raising your hand, unmuting. Anyone in person? What could we do in a situation like this to build some rapport with Colin and his mom and work through the situation?
I think one thing can be is to kind of normalize in medical care setting. It's not uncommon that we sometimes meet with alone, just to get us some information and one if that could be an opportunity for the child to be able to spare and doing as a moment.
Yeah, I love that. Using that normalization, right? That like, typically what we do is we like to spend some time with the young person on their own so they feel like they can speak freely. But while you're here, is there anything you want to talk with us or there are questions you have? So making sure that they both get a bit of that time with the team. I love that.
In the chat, we have 2 responses that are very similar as well. So meeting with them separately so that both can feel heard.
Yeah, Vivian and Dolly look like they're on the same page with that one. And almost front loading that at the start, right? Like maybe right when they come in saying, oh, like typically how an appointment works is we will, if the family wants to be involved a bit at the start, so we can take any information or have any questions from you. And then we will have the majority of the appointment being one-on-one with that young person. And again, if the young person says, I want my family to stay with me longer, then great, but we're taking their lead, right? Yeah.
And I think just having a little empathy around maybe possible family dynamics where, Colin might have a lot of shame or guilt for feeling suicidal or struggling with mental illness. Maybe his younger brother has no problems getting A's in school and, Colin's really struggling. And so he doesn't want to burden the family more. So really kind of having a bit of a family picture, because that is also a tool we can use to help the family deal with the stigma or deal with the fears of either mental health or suicidality. And so really they can all come together because we know again through the research, if you have family support, that really helps better outcomes.
Mm-hmm. What I really like about this scenario too is I think we really want to maintain the rapport with that young person and help them feel like it's a confidential space where they can speak on their own and kind of work towards that independence. So we really want to do that. But sometimes in doing that, we can dismiss the family or make that caregiver feel like they're being excluded or like there can be a lot of anxiety. And so I really like that all of you were talking about how there's a really great way to balance both, right? I think in adult care, in some settings, family tends to be involved quite a bit less. And so there can be a lot of feelings from the family about being confused about what's going on or a bit anxious that they're not maybe getting to share some of the things they have that would be really helpful. Steph has had a couple examples of a case where she did a one-on-one with a young person and then had one idea of the clinical picture and then went to collect information from the family and got a very different story about what was going on from then, right? And so we know it's really valuable to get both.
One thing I've worked with young people around is when you can have a bit of an individual conversation is how would you like your family to change so they can better support you? And we don't have to be family therapists, but we can kind of help coach the family through some basic ideas.
Yeah. One example of a youth we spoke with who had eating disorder treatment was they found that their mother, they had quite a strained relationship in their teenage years and the mother didn't really understand eating disorders. So did a lot of quite dismissive behaviors and the teen said that they wished that the team had asked them, hey, what do you need in order for you to want your mother involved more? And they would have said, I want my mother to be getting education on this so that she can be brought in. She wants them to be educated first and then brought in so that she can be more therapeutic because the involvement wasn't therapeutic at the start. So really simple questions, but you can get so much value out of that, right? Right. Thanks for everyone's participation. We are just going to move over to Otto.
So we just on our last part of the presentation. I'm gonna talk a bit about working with diverse families, including different cultures, different beliefs. So as clinicians, we've all been exposed to some training in cultural safety. So for those of us in BCH, you might have taken courses through Learning Hub. Or you might have taken courses on your own around cultural safety, competency, or justice, diversity, equity, and inclusion. So when we practice family-centered care, it's really important to consider our biases and values and how they might differ from those from different cultures and experiences. When working with families, we might encounter situations where they really might have a different cultural belief or understanding of what the problem is. Maybe they don't see it as mental health, or they might have a different view around medications. Some cultures have really strong stigmatization of mental health, so they might lead families to avoid care or contact with supports. Some cultures might have more of a collectivistic, community-centered value, which might not be centered in the Western individualistic biomedical model. And last time I mentioned reading a book called Indigenous Healing. So, and I grew up with this, right? Survival of the fittest. We all were taught a bit about Darwin in high school. And the Indigenous way of looking at that is in relation. So instead of like survival of the fittest, each, the earth, the animals, people, we're all in relation to each other. And to me, that just kind of hit a light in me where it is really that fundamental. And of course, language barriers can make it challenging. So we try to seek to understand family concerns and priorities. We try to provide education and recommendations and empower clients to direct their care. We can use translators, even if some families speak some English. We've kind of all been there. We might have used a family member, usually a child, to translate, but it kind of puts the family maybe in an awkward situation as well. So when we can, it'd be nice to have translators.
Research has actually shown that it's been quite harmful for like the young family members, like the sons or daughters that are being asked to translate on behalf of family, because it's putting them in this role that they shouldn't be needing to do at that age in terms of that caregiving role. And so, yeah, that's a big learning for me over the last couple of years, is just because some English can be spoken, there could be so much nuance that's missed. So yeah, I will almost always get a translator now.
There's also, I'm not sure if anybody on the call or here also works in the emergency department at Richmond Hospital, but there is actually a research project going on right now. And they are trying to get participants where at triage, if someone is identified with having anything related to like chest pain or heart concerns, and they have English as a second language, or maybe their English is not at 100%, or there's any reason to suspect that, they're actually being offered the interpreter on the stick. So they have 4 sticks available, and they're really encouraging staff to utilize that, especially given coming from Richmond and being near the airport. You can imagine that there's a number of different languages that can be spoken, and so it is really important to understand those nuances.
That's great.
Yeah.
And for me, I speak a little Cantonese, so I'd be the worst interpreter. I can maybe order dim sum, but I cannot translate for my mom. So to really understand, there really are some limits around that. And we can also consult with ethics department when we have more complex cases, right? Really where there might be competing demands and competing beliefs. So the meaning of family. Extended family can play an important role in the parenting of children. Aunts, uncles, grandparents, cousins, elders, friends, older siblings might play a role comparable to this Western European idea of parent. The community as a whole can be involved in raising a child. Certainly, within different cultures like South Asian, Asian, Indigenous. The North American capitalist social structure, so it's really focused on individual rights, freedoms, and personal success. And other cultures and community might focus more on the community, more on the family as a unit. And particularly for Aboriginal social structure, so we talked about this idea of non-competitiveness and sharing. May place family and community success ahead of individual success. And it provides a social safety net for each individual.
One thing we have heard from some youth in our focus groups is that because they were a bit more reliant on their family due to their family's culture, they felt some judgment from the healthcare team that they were immature or that they weren't being independent enough. And so just being aware of dynamics like that for sure, right?
So when we work with Indigenous families, it's only a generation or two since the extended kin networks of parents, grandparents, clan members made up virtually the entire social world for Aboriginal people. And that Aboriginal families and the cultures and identities they passed on to the children were severely disrupted, unfortunately, by the actions of colonial and Canadian governments. Children in particular were targeted time and time again in the official strategies to control and assimilate Aboriginal people. And sadly, as we know, through residential school, through the Sixes Coup, through just very systemic racism and discrimination. So the impact on individual and families, and we see this as they come into our service too, right? Where they might be isolated and alienated. There's a lot of losses and unresolved grief. They might have difficulty with parenting because of the loss of stories, identities, kinship, and traditions, being separated from their own families or being separated from their nations or their reserves. There's a lot of shame, internalized racism. I've noticed this a bit too, like self-hatred and low self-esteem. And maladaptive coping behaviors, substance use, gambling, and alcohol. So there's a person named Bruce Alexander. He's a psychologist from SFU in the 70s. You might have heard of him. He did the Rat Park study on substance use. One of his theories I find really insightful is he called it dislocation theory, where people are, when they're dislocated from their social and community, become more vulnerable to substance use. And I think that's part of the impact for Indigenous people. They might be angry or aggressive or cope through violence. And there's a fear of authority as well. So the next slide. And then on a community level, there's a loss of connectedness with language, traditions, and cultural history. There's a loss of togetherness, collective support. They might be disconnected from elders. They might not even know how to access elders. There's a lack of control over the traditional lands and resources, increased suicidality. And you might hear from time to time, small Indigenous communities, there's a state of emergency because there's been a lot of parallel and frequent suicides.
I think there's 3 communities on Vancouver Island that have a
Yeah,
state of emergency right now
recently.
related to
Yeah.
Toxic drug overdose. Yeah.
Yeah, just recently too. And there's an overrepresentation in the child welfare system and a lack of communal raising on children. Increased dependency on others and communal violence. So on Turtle Island, colonially known as Canada, there's been evidence and studies and dialogue to show that cultural continuity have been found to be a key protective factor against suicide risk. So, and we're always looking for those protective factors, right?
Mhm. A big thing a youth participant talked to us about is they said a really great way to work with youth is to ask, oh, like, are there any considerations about culture that we should consider in your treatment? Because this particular youth they were passing and did not look Indigenous, but they were Indigenous. And then if someone said that they weren't very connected to their culture, saying, oh, is that something that you've always wanted to be more connected in with? Because we can also, so just because an Indigenous youth might not be connected in with their culture, that doesn't mean they're not interested or maybe wanting some resources for that. So just again, asking more of those questions and not making those assumptions was something that I really learned from them.
And so this was in plain sight, and some of you might have read the report back in 2020. And unfortunately, it's based off reports of racism. I think, was it in the ER or?
Yeah, it started with a report
Yeah.
from an incident in an emergency department in the Lower Mainland.
And so that led to this commission where they interviewed over 8,000 people, including healthcare providers, patients, families. And they found, unfortunately, persistent stereotyping of Indigenous people that were common and widespread. Examples related to family-centered care is judgments made about Indigenous parents as bad parents. They must be doing something wrong. Interactions with social workers or MCFD representatives were noted by multiple Indigenous respondents as something they or their family were particularly fearful of when they're visiting hospitals or giving birth due to concerns that their child will be apprehended. You know, and that's a fear we don't really have when we go into maternity wards when we're giving birth to a child, right? I don't have that thought. And unfortunately, this is kind of a persistent fear, and the impact of intergenerational trauma.
And also just to note as well too, when we talk about the Mental Health Act and certification, often, and I've heard from Indigenous parents as well, that it does feel like another form of taking their kids away, right? Because especially if they're not in agreement with the certification, I think it's one thing to acknowledge that we do need help, but then sometimes if it's an involuntary admission or extended leave, I have had parents say to me that it does feel like just an extension of what has already happened. So just something to take into consideration, and also knowing that in Canada, we have the strictest mental health act across all of the provinces. And that is something that's being contested quite frequently right now. So just something to consider when talking about involuntary admission or extended leave.
Another really interesting note in the DSM as well is that I believe it's for psychosis, right? But do you want to speak to that?
Yeah, we a youth participant had shared that they were quite concerned about elaborating or providing any details on their Indigenous practices, especially with use of like Indigenous medicine or
Sweat lodges, I
the
think.
sweat lodges. And for those of you who are not aware, in the sweat lodges and when using some additional Indigenous medicine, it is quite common to possibly see or hear or experience things that maybe are out of body. And this youth participant had shared with us that they actually were really fearful of sharing that with the care team for concern that they would be, you know, certified, you're hearing voices, you're seeing things. And so they really felt like a huge piece of their care could not be shared with their team because they did worry about the implications of that. And this was actually interestingly also something that we heard from a parent as well who does practice not Indigenous medicine, but alternative medicine, where a common theme of not being believed or maybe being seen as maybe not mentally stable because of some of the things that they're choosing to practice. And so, yeah, we did hear that from a parent as well as a youth that had received care before. So just something to keep in mind under the DSM-5, there is a stipulation under psychosis that it does exclude any culturally, I guess, significant like concerns or
Like it's spiritual experiences
Yeah.
related to a cultural practice.
Yeah. So that's exclusionary criteria. Yeah.
I mean, we're going through some clinical research in the States. People of color were more likely to be diagnosed with psychosis, like beyond what the expected rate would be. So, and then as we go to the next
I
slide,
think we haven't gone into the bottom yeah,
Oh.
around the overrepresentation.
Oh, okay, sorry, I got ahead of myself. I'm so keen.
Fired up.
Fired up. So according to census data in 2021, 53.8% of Canadian children in foster care are Indigenous, but they only account for 7.7% of the child population. So why is this? Why is there such an overrepresentation? In Ontario, Indigenous children are 3 times more likely to be investigated in the child welfare system as white children. So unfortunately, I think there's just systemic practices. So how can we show up for our Indigenous clients and their families? Any ideas around that from online or here in the room? Like what do you think would matter or would be helpful? Like in your experience?
And this is our last discussion question. So recognize the discussion fatigue during education sessions. But yeah, this will be our last discussion, and then we'll be moving to some concluding bits and a wrap up after this. Any thoughts from anyone that wants to throw it in the chat, unmute, raise your hand? Anyone in person? These are likely things some of you are doing already, so very interested to hear practices that you've already been doing for this. Mhm. Yeah, so really that curiosity piece, right? I think in healthcare, sometimes we worry about how we always need to have competence. They've moved away from the term, but cultural competence, right? None of us will ever be able to be competent in every culture that's out there, and each person within a culture might practice it in a different way. So I love that you're talking about leading with curiosity. And just to pull another example from this is around neurodivergence. For a lot of neurodivergent patients, they say that it's not so much that they expect their healthcare provider to be an expert in providing care to someone who's autistic, but just that they show curiosity and ask questions so that they can learn with them, because we know that each person has unique needs, right? Yeah, so I love that you're talking about leading with curiosity.
Couple responses in the chat. So Sean suggested discussing and acknowledging past challenges they have experienced in the system. And then from Vivian, educate ourselves, listen and acknowledge their experiences. And then from Joshua, meet them at where they're at. Yeah, so these are all great responses. And I think it is important. There's so many opportunities within Vancouver Coastal and in the healthcare system to educate ourselves. And that can look really different for each person. And so whether that's talking with your patients, taking an online course, there's so many things that you have available to us, especially with access to so many great programs and services. Yeah.
So connecting families to services, like if they're unsure, they have questions, they want to about their culture, like we mentioned previously, they want to learn more about their culture and they're unsure.
Yeah, and a lot of hospitals have Indigenous liaisons as well. So that's now, I don't know if it's common practice in Vancouver Coastal, but in PHSA as well as Fraser Health Hospitals, it is a question that's asked at triage. Not only for statistics records, but also as an opportunity to provide them with the resource to an Indigenous or Aboriginal liaison staff member. And that can occur at the time of triage, or it can occur later on in their treatment when they're admitted, or even once they've been discharged. Say they didn't have a really great experience and they want someone to talk to about it, that's a service that's available to them as well.
I think sometimes it's hard to hold these values when, like all of us have been at work where you're burnt out, you've got huge caseload. You've got your own pressures from personal life, you have families, maybe we're also struggling with, our own mental health or illnesses. And it's hard to put these values into practice when moment to moment, we're tired and fatigued. And so we're not perfect, but to find a way where we can really connect what speaks to us. And one of the things Sarah, Steph, and I have been privileged is through Provincial Health Services they were gifted the Coast Salish teachings, and there's, I think we can.
So I can put a link.
Yeah, but some of those really spoke to us, like around truth, that we are one, and to deal with open minds and hearts. That, we don't have perfect, but certainly there's a sense of feeling humble, right? As we work with those who have been so oppressed.
I went to a really great two-eyed seeing workshop. And we'll talk about the concept of two-eyed seeing in a second for anyone that hasn't heard it. But they talked about how in Coast Salish history, there are multiple ways that a person is considered wealthy. And one of the main indicators of wealth is being able to trace back your family line and know where you came from and know those traditions. And so I think just that piece about that cultural continuity is just because someone to this point in their life has not been very connected in with their culture, they might really be seeking that. And I think we've seen that for a lot of Indigenous folks where in their adult or young adult life, that's a time where they start to really try to learn where they came from and reconnect with that, and how that can be such a therapeutic part of kind of coping for them and coming back into a community that they felt that they weren't able to have when they were younger due to a lot of those colonial structures. Back to you, Otto.
Okay, so maybe we can look at some of the things here. So we can understand, and I think a lot of you have done some of this work around intergenerational trauma, understanding ACEs or adverse childhood experiences, and social determinants of health can impact family and health. Sarah mentioned two-eye seeing, where we can incorporate Indigenous ways of knowing and healing into treatment to complement Western biomedical approaches. Asking them if there's anything from their culture that would be helpful to consider or incorporate into treatment. We talked about involving Indigenous liaisons, elders, spiritual healers, Indigenous patient navigators, considering things like smudging, sweat lodge, drumming, or coping or well-being strategies, looking at a patient holistically. So not just the symptoms, but really the whole social context. And encouraging participation in care planning, again, with the patient, family, friends, chosen family, kinship, their community. Tuning in or attuning to those who are dysregulated, using empathy, really trying to understand what's it like to walk in their shoes, understanding the life state of mind, and compassion, really feeling with them. Lifelong learning, critical thinking, and being active bystander. So I always think about where am I and how am I feeling in this practice? What's really speaking to my heart? What's really speaking to my practice? And finding support and healing from your own trauma so you can be less triggered with the people you are helping. And I think we are so good at underestimating how hard the work is for us, right? We minimize it, we compartmentalize it, we keep doing it, but we never give ourselves a break to really check in. And to build a strong self-care practice and support network.
So as we come to the end here, just wanted to highlight so this page has some resources for healthcare providers. Just a few to highlight. We talk about Compass all the time and toot their horn because they're amazing, but anywhere in BC, teams can call Compass and they can get support with MHSU clients 25 and under. This includes physicians, allied health, any care team. So if you're ever really unsure about resources or a treatment plan or medications for a young person, they're really great to reach out to. We've included also some toolkits in here for families. We've included Family Smart, which is great for families to connect in with family peer support workers. And then just also wanting to highlight again that VCH FAQ on family involvement and some resources for families. So in addition to a lot of the ones we know, like Kelty for evidence-informed information, supporting families is really that Richmond specific location for supporting families. The Sash Bear Foundation has free workshops for families anywhere in BC that are DBT focused. So for family members to learn DBT skills to support young people that are having issues with coping and regulation. We know that through Foundry, we have that drop-in caregiver counseling, and shout out to Sean on the call, one of the youth and family caregivers at Foundry. We also have the BC Schizophrenia Society. So contrary to popular belief, they're not just a service for those with schizophrenia, but BC Schizophrenia Society provides service navigation and supports for families for anyone who's experiencing any severe mental health. And so they can really support in terms of that service navigation piece.
And they have support coordinators in each region, so one for Surrey, Fraser Health, one for Vancouver, Richmond.
Mm-hmm. And we have included a few toolkits on this page that have been written by caregivers for caregivers for supporting the things like substance use and mental health with their loved ones. So that's the end of our presentation. We do have a QR code here just to scan for the post survey. And then we have a bit of buffer time for any questions or any discussion that anyone wants to have. But we really appreciate all of you taking time out of your busy day and potentially out of your lunch break to learn with us today. We do have another session later this month that is a lunch and learn specific to the confidentiality content of this. So if any of you attended today and missed the confidentiality portion, that's what will be happening. If you attended the full session today, then don't bother coming to that because it'll be the exact same content and quite boring for you, but it's been really great to have you all engage this month. And our topic for next month will be discharge and transition planning. So we'll be sending out invites for those education sessions near the end of March.
We've also attached the post survey code in the chat for anybody who is unable to scan the QR code as well. And there is an opportunity to win a Starbucks gift card if you complete the post survey. So there's an option for you to put your email in. We promise we won't send you anything except for a gift card if you were a chosen winner. No memes or anything from me, but feel free to reach out as well to our email, and we will be sending out the slides. And within the slides is a PDF, all those resources that Sarah talked about and more will be linked. So you don't have to Google them on your own. We've linked to them and done all that for you. So please complete the survey, and you'll hear back from us whether you've won a Starbucks gift card.
And we continue to be available for any community teams in Richmond that are looking for support around young people 16 to 24, whether it's about family-centered care, confidentiality, or about any other challenges that you're navigating as a team. We're always happy to come to rounds, care plan meetings, just do calls with you if you want to chat through anything or share some resources over email. So reach out anytime.
Thank you guys for all attending. We'll stick around for a couple more minutes here and give people the opportunity to complete the survey. And if anything isn't working, just let us know. If not, I hope you all have a really great rest of your day and get outside and enjoy some sunshine. It's cold, but it's bright. So that's always nice. Yeah, thank you guys.